All right, I have 7 o'clock. You all ready? Cool, can you hear me okay? Perfect. Okay, full disclosure, I live in a house with 5 other people. And my cat is in here with me, and sometimes he's obnoxious, so I apologize ahead of time for any background noise. All right. So the grades for the ATI final are posted in Blackboard, so if you kind of want to get an idea of where you're at, they are available to you. You are welcome. I know that it's stressful for you guys trying to figure out what your grade is and know what your standing is, so I try to get those posted as quickly as I can, just to help give you guys a better idea of what's happening. Cool. All right, let's go. You guys like my Mona Lisa? I feel like it's very applicable to what you're probably feeling like this week. All right. So electrolytes. Remember, by way back in the beginning, we talked about electrolytes. So we've got somebody in the ER with a sodium of 114. Is that enough? All right. Which findings would the nurse relate to the serum sodium level? Select all that apply. What do you think? Oh, you can't see it? Okay, so we've got a vote for muscle weakness. Yes. What about headache? Is that associated with sodium? Yeah. Confusion. All the neuro stuff, right? Is what I always think of first when I think of sodium. Warm flesh skin, not so much. What does our skin look like? Is it warm and flushed? What's the opposite of warm and flushed? Yeah, cool and clammy, right? And then abdominal cramping, yeah, they can have some abdominal cramping because you've got some GI motility that goes up. So they get some abdominal cramping. So if that didn't just come right to mind as we went through it, just make sure to do a little review of your electrolytes. So we have an experienced LVN. I think I have shared this question with you guys before, but the client's blood pressure and heart rate have decreased. And when the face is assessed, one side twitches. What electrolyte imbalance would we associate with that? Right. So what this question is trying to pull out from you is that you've got some signs and symptoms of hypokalemia, right? And so, yeah, magnesium is kind of tied in with your calcium, right? But they're trying to keep you from being dismissive, and they're trying to associate it with that calcium level. So when we're talking test taking strategies, they give you the information they give you intentionally, right? That blood pressure and heart rate, you need to know that, and that paired with the face twitching, that's which sign is that? You get brownie points if you can spell it right. Yeah, something like that. Yes, that one, right? And then trousseau's is the hand, like claw looking thing. I can't spell either, so I just like trying to make you guys try to spell them. There you go. So yeah, when you're looking at a question, the details are important, okay? All right. Moving right along. So we have a nurse in a provider's office reviewing the lab results of somebody who takes furosemide. So what do we always associate furosemide with? Always potassium, right? It is a diuretic, but specifically a potassium wasting diuretic, right? And you've got this potassium level of 3.3, so it's doing its job of wasting potassium, right? What are we going to watch for? So what is a complication of hypokalemia? Right, so your heart is really upset when you don't have enough potassium. It gets upset when you have too much too, but hypoglycemia is not right. Seizures is more associated with which one? Which electrolyte imbalance? Yeah, sodium. And the neurogenic shock, that's just like, they're just making stuff up. That's something entirely different. So, okay, so that's all you get of that. Acid-base imbalance. If you have not looked over this, you need to look over this. There will be several questions on acid-base imbalance that you will need to be able to do. So we have an unlicensed assistive personnel telling you, your patient is anxious. So you've got the anxiety piece, and you've got a respiratory rate of 30. Okay, so just from that information, are you expecting this to be a respiratory or a metabolic? Right, it's respiratory, right? We have an anxious person with a high respiratory rate, so we can eliminate C and D right off the bat. And then you have to remember what happens when you have that increased respiratory rate, right? You blow off your CO2. And when you blow off your CO2, then what happens to your pH? Yeah, your pH is going to rise. And so we have, as you guys have said, a B, respiratory alkalosis. Everybody following? Perfect. All right. We've got an NG tube. Okay, so NG tube, are we thinking respiratory or metabolic? Right, doesn't have anything to do with your breathing, right? Student nurse asks why the respiratory rate and depth has decreased. Ooh. What's the nurse's best response? So I've got an NG tube. What is my NG tube pulling out? Acid, right? So what is that going to make my pH do? Yeah, it's going to raise my pH. And so what happens when I decrease, all right, yeah, I decrease the respiratory rate. What am I doing? Compensating, right? So what happens when I decrease my respiratory rate? Why am I doing that? Yeah, I'm trying to hold on to CO2. When I hold on to CO2, I'm going to bring my pH down, right? Okay, so let's read through our answer choices. It's common for clients with uncomfortable equipment, such as an NG tube, to have lower rate of breathing. That's just false, right? It would actually be the opposite. B, client may have metabolic alkalosis. Ah, that sounds promising. Due to the NG tube suctioning, yes. And the decreased respiratory rate is a compensatory mechanism, yes. Okay, we like that one. C, whenever a client develops a respiratory acid-base problem, decreasing the respiratory rate helps correct it. Not always, right? That's not 100% correct. So it's a partial truth. And then D, the client's hypoventilating because of anxiety. That's just right out, right? People don't hypoventilate when they're anxious. Okay. Nurses providing care. Ooh, you guys love these. I know, these are just your favorite in the whole world. Several clients at risk for acid-base imbalance. Which client is at most risk for respiratory acidosis? So respiratory, it's got to be a breathing problem, right? Acidosis, so something that's going to make my pH go down, right? So I can automatically eliminate which one? A is right out and D is right out. Okay, so it's going to be either the anxiety patient or the emphysema patient. So we're thinking respiratory acidosis. So who has respiratory acidosis, right? The person who's going to hold on to CO2, which is your chronic emphysema person. Yeah? Okay. And your anxiety patient is going to raise their pH, right, with their rapid breathing. So that'd be the opposite problem. Your patient has ABG results as follows. You won't get a question this easy, by the by, but it's just your practice. So what are they in? Are they acidotic or alkalotic? Alkalosis, right? And then which one is changed? Yeah, my bicarb is out of range, right? So am I a respiratory or metabolic? Yeah, so my answer is B, right? If this is not something that's easy for you, go back and look at that Rome mnemonic because it really helps you determine what you're looking at. It's in your book, it's in lecture. Yeah. Nurses reviewing medical records for clients who have an acid-base imbalance. The nurse should recognize that which of the following clients is at risk for metabolic acidosis. You probably won't get a question this easy either. You might get some lab results and then you have to pick one of these. We'll probably do that. So who's going to have metabolic acidosis? What do we think? And this one's a little bit confusing. Yeah, so why is it B? What are they losing when they have diarrhea? Yeah, so they dump bicarb when they have diarrhea. Well, they could lose sodium too. But yeah, they're getting rid of bicarb, so that can make them acidotic. Okay. Y'all with me? Cool. All right. If you have not cracked open that purple ATI book, I highly recommend you look at it at least for the acid-base imbalance content because it's amazing. That's my pro tip for you. Okay, so for acid-base, make sure you do review a little bit about compensation. We've already talked about it in a couple examples tonight. How would you compensate for whatever imbalance you have? Okay. And as we go through this review, if I give you a slide and give you specific things that you should review, you should probably review them. Just saying. And then conditions with associated imbalances. So that's what that little purple ATI book is good about doing, is giving you a list of different conditions that would fall under which acid-base imbalances. Okay. All right. Flying through. Now we're in heart failure land. You have a healthcare provider who's written orders for a client with the diagnosis of pulmonary edema. What's the problem with pulmonary edema? Yeah, but what's bad about it? Yeah. Is it bad if you can't breathe? Yeah, it's no bueno. Yeah, it can lead to death, right? Because you are drowning in your own fluids. Terrible. Thank you. That's why we harp on certain things, right? Like pancreatitis. How many different ways can your pancreas kill you? Because you need to know these things. All right, so healthcare provider wrote orders. We have somebody with pulmonary edema. Okay, so now it's going to give us some details. Morning weight assessment reveals bounding peripheral pulses. Is that right or left? Mm-hmm. Weight gain of 2 pounds, right or left? Mm-hmm. Pitting ankle edema. Moist crackles bilaterally. So this person has both, right? Remember, your left can fail and lead to failure of your right. right? Okay, so is our patient happy, calm, resting quietly in their bed? No, this patient's in some distress, okay? They feel probably pretty rotten. So when we're talking priority, would weighing the client in the morning be our priority? What about charting something? Is it always a good idea to chart something? When in doubt, just chart. Just sit down and chart. You're just like sitting at your, like your little rolly chair, staring at your patient who can't breathe. Doing all right? Restrict fluids. What's the problem with that? Is it kind of late for that? Restricting fluids? It will help, but it's not going to help fix where they're at right now. So that's why it's D, right? Let's give them some Lasix. Let's double check their potassium level. But we got to fix them, and that's the only intervention that's going to help fix the problem. Which topics will the nurse plan to include in discharge teaching for a client who's been admitted with heart failure? Select all that apply. So with the select all that applies, some of you guys like to pick, like you think that there's only ever 3 answers. So you only ever pick 3 of them. And this might be like a strategy that you have in your life, but it's not only ever 3 answers. Sometimes it's all the answers. Sometimes it's 4 answers. Sometimes it's 2 answers. Sometimes it is 3 answers. But read them all. Don't just like pick 3 because like that's your strategy. Because then you miss them all because you only pick 3. Make sense? You guys are just jumping to answer. Okay, select all that apply. Daily weights, yes, we like that one. B is no, right? Does your heart rate naturally increase when you exercise? Yes. Symptoms of worsening heart failure, absolutely. We need them to know that. Purpose of chronic antibiotic therapy. Are they going to be taking chronic antibiotic therapy? No, that is wrong. How to read food labels. Is sodium in freaking everything? Can we just have a moment of silence for the fact that sodium is in everything? For the love. And sugar. It's like, it's spaghetti sauce. Like, why does there need to be that much sugar? Oh my good. Coconut water for the reals. Yes. All right, and date and time for follow-up appointments. Yes, for the love, go to the doctor. Okay. So that would be, that's like 4 answers, right? Of 6 possible. Don't be afraid. Pick all the correct answers. All right, moving on. Somebody's got some shortness of breath and fatigue. They are being evaluated for heart failure. Which lab test would be most useful? What do we look at for heart failure? Thank you. Check their BNP. Also, patient teaching is muy importante, right? We already did a patient teaching question, but make sure that you know that. You will be tested on it. You just will. Okay, for this one, what would be a priority nursing diagnosis for somebody who shows up with shortness of breath and fatigue? What do you think? Any guesses? Could be activity intolerance. What else? Something about the oxygen, right? Maybe like something about gas exchange. Yes, thank you. Hypoxia. Sure. Yes, something about the breathing. Okay? Don't talk to me about like, what are some of the ones that are like they can't participate in their like extracurricular activities. I don't know. Like some of them are just like, what? That's not a priority. We need them to breathe. If they're not breathing, they die. So just think about when you're thinking about nursing diagnoses, which of these can kill them, and that's your answer. The nurse is caring for a client who has heart failure, reports increased shortness. We already did that. No, we didn't. Different question. Nurse increases the patient's O2. Okay, so they've got heart failure, they've got shortness of breath. They increase the O2. Which should we do first or next? Now, this is a tricky one. You guys will not be confused. Yeah. So obtaining their weight will not do us any good. Will we obtain the weight at some point? Yes. Auscultating the lungs, we will do that at some point, but that's not going to help them, right? O2 sat, we will check the O2 sat, but that's not going to fix them, right? We want to sit them up because that's immediately going to decrease that venous return to the heart, right? What acid and base imbalance are they at risk for? Bonus points. It's tricky. So they don't have good gas exchange from their heart failure. Okay, so it's actually a combination of, yeah, metabolic and respiratory acidosis, because metabolic because they can get lactic acidosis, and then respiratory acidosis. So we won't give you anything that's confusing. It'll be straightforward. Okay, for heart failure treatment. Okay, know what medications we give people and what the side effects are. So if it's got a side effect, like we always harp on furosemide, right? But there's other heart medications that have side effects, like beta blockers or digoxin or something like that. You need to know those, why they take them, and what side effects can be. You guys get really confused about the signs and symptoms of decreased cardiac output, kind of across the board. So make sure that you know what the signs and symptoms of decreased cardiac output are. What does it look like on your patient if their heart is not pumping out enough blood? What does the stage or S3 gallop mean in heart failure? I'm making stuff up. What does it mean though? Is it a normal finding in heart failure? So it means left ventricular heart failure, right? Volume overload. You've got some valve regurgitation, can mean hypertension. Yeah, so it is a sound that you can hear in heart failure, okay? Make sure you know the stages, classifications, 1, 2, 3 of heart failure and what kind of signs and symptoms might show up with those, okay? So which one is worse, a 1 or a 3? Compensatory mechanisms. Remember, your body tries to fix it, but then it makes it worse. So review on that. And then what are the complications of heart failure? All right. A couple more. Nurse is caring for somebody with heart failure, taking DIG daily. The client refused breakfast and is complaining of nausea and weakness. Might you need to know signs and symptoms of digoxin toxicity? What do we do first? My favorite is C. Why don't you just sleep it off? Just sleep it off, you'll be fine. Thank you. We're going to check vital signs. What are we looking for? What can DIG do to you? Why do we check their vitals? Yes, heart rate can get low, right? Yeah. Cool. Moving on. So they throw this, back to this for a second, request an order for an antiemetic. They put that in there in case you don't know that nausea and weakness is a side effect of DIG toxicity. Okay, this is the one saying you don't know what we're talking about. Okay, so make sure that you read those details. They give them to you intentionally. So test taking strategy, right? Cool. All right. Pulmonary edema. We have somebody with suspected pulmonary edema. Which of the following manifestations are expected? What are they going to look like if they've got pulmonary edema? Select all that blood. Yep, so tachypnea, fast breathing, yes. What else? Cough, yes. Are they going to have increased urine output? No. Remember, when your heart is failing, you don't perfuse your kidneys. When you don't perfuse your kidneys, then you're not going to have as much urine output, right? Remember, urine output is one of the main ways we can measure what our cardiac output is. Okay, thick yellow sputum, that's not what happens with pulmonary edema, right? What does it look like? Yeah, pink and frothy. And then orthopnea, what do we think about that? So it's hard to breathe, like depending on how you being. If you're laying flat. Yes. Yeah. So yes, E. So our answers are A, B, and E, right? Everybody with me? Okay, thank you. Okay. ACS, my favorite. Okay, we have somebody who arrived at the ER, substernal and left arm discomfort, 3 hours. What lab we gonna do? Please don't get this wrong. Thank you, troponin. We're gonna do other ones too, right? But troponin is gonna tell us specific cardiac damage. What are the complications of a myocardial infarction? And how would we know? Complications of myocardial infarction. Yeah, so cardiogenic shock dysrhythmia is yes. They can also get heart failure, right? Yeah, there you go. Very good. So we would look for signs and symptoms of heart failure, signs and symptoms of dysrhythmias. We'd want to do an EKG, right? You want to do an EKG anyway to rule out ACS or to rule out MI, I guess. Okay, remember, priorities are everything and time is muscle with ACS. So we want to try to get to the bottom of what's happening with the patient. We need to get that EKG because that tells us what's happening as far as if we have ST segment changes, right? Remember, we've got stable versus unstable. Which one is worse? Yep, and remember, stable can progress into unstable, which can then progress into NSTEMI, which then can go to STEMI. Remember, stable is predictable. We do a thing and it hurts. We rest or take some nitro and it goes away and it doesn't last as long. But with unstable, it doesn't matter what you're doing. You could be doing stuff or not. It's going to get worse and more frequent and last longer. And then the pain just is more intense and usually progressively is just getting worse instead of better. So no matter what you do, you can't make it go away. Okay. Okay, what is ischemia? Yeah, so we don't have blood flow. When we don't have this blood flow, we don't have oxygen, okay? And so when we don't have oxygen, our tissue dies, right? So lack of blood flow, lack of oxygen, and if we don't get blood, we don't get oxygen, but what else do we not get? What else does the blood bring to the cells? Yes, so we're not going to get nutrients, right? And then if we don't have circulation coming to the tissues, what cannot be carried away? Yeah, CO2, any other waste products, okay? So, ischemia is a lack of blood flow. Pay attention, please. This lack of blood flow leads to lack of oxygenation, right? Correct. Lack of oxygenation, we don't get proper nutrients, and then we can accumulate waste products. Y'all with me? Sweet. All right. Stress test. We got this client doing a treadmill stress test. Which one makes them fail? We get you every time on this one, every time. Okay, so stress test. If I were to put you on a treadmill and make you run, would your blood pressure go up? Yes. Would your heart rate go up? O2 sat. Okay, I'll give you the fact that O2 sat is not ideal. Maybe they smoke 2 packs of cigarettes a day. Maybe they're asthmatic. But does it have anything to do with them being on the treadmill stress test? Why are they on the treadmill stress test? What are we trying to elicit? Yes, right. We're trying to make the heart misbehave. So we put them on the treadmill, they start having chest pain. Bingo, you failed. Okay? So the chest pain is the problem. Chest pain is never normal. Correct. So any signs and symptoms of ACS, chest pain, they fail. Okay? So it's the chest pain. If you have any question about anybody with anything related to ACS that has chest pain as an option, that's your answer. Okay? So the chest pain equates to ischemia, okay? And ischemia can lead to injury or infarction, right? Everything else is a normal response. Maybe not the O2 SATA 91, but it's not as bad as the chest pain. I know it's a little counterintuitive, but just go with me on this. I'm going with the 2 packs of cigs a day. 53 doing a stress test. I mean, that's awfully young. There's got to be some underlying modifiable risk factors, right? Most 53-year-olds are not having heart attacks. Okay. Maybe they're diabetic. Who knows? Nurse is caring for a patient after an angioplasty. They went through the femoral artery, so they had a heart cath, okay? When turning the client, the nurse discovers blood underneath the client's lower back. Is that normal? Nah. Which of the findings should the nurse suspect? So let's start at the bottom. D, heart failure. Is the blood underneath the client's lower back have anything to do with heart failure? No. What about C, bleeding from the incisional site? No. Cardiac tamponade. No, they're making stuff up. Retroperitoneal bleeding. Do we like that one? Yes. Very good. So do a little, again, pull out your little purple ATI book. It gives you a rundown of all these diagnostic procedures, all of these other just like procedures and things to look for, okay? You need to know it. Also, if we went through the femoral artery, what could be another complication? Like, what's another assessment thing we're going to do to make sure that it's all legit? So DVT, yes, but that takes a hot second. Yes, perfusion, thank you. So you can have, because you went in through the artery, right? So you could damage it and then not get good perfusion down to the toes. So yeah, numbness, tingling. How do we assess that? You can ask them, I guess. But what's a physical assessment that we do to check for that? You can do cap refill. Pedal pulses is what you do. You're going to check pulses to make sure you got good, strong pulses down to those the feet. Okay. All right. Renal, 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 renal. Okay. We're going to go through this quick. Know the types. Pre, intra, post. Acute versus chronic. What are the clinical manifestations? Okay. So, oligouria. What is oligouria? Yeah, not enough urine output. We get some fluid overload, and then what happens? Right, we can get an edema, and then what gets stressed out when we have fluid overload? Yeah, yeah. So your kidneys are stressed, that can lead to some heart problems, right? What acid-base imbalance are your renal patients going to suffer from? Yes, thank you. Metabolic acidosis. Signs and symptoms of fluid overload. So edema, you guys said. What else? It's all the right-sided stuff, right? Yep, JVD. What about your pulses? Yeah, bounding peripheral pulses. Yep, you can be hypertensive. Very good. They get hyponatremia. They get hyperkalemia, leukocytosis, elevated V1 and creatinine, and they can get neurologic changes. What are the most common causes of death? No. It's okay. Put it out there. No. Infection. Yep. Infection. So you want to check and make sure that they, yes, which can lead to death. Yes, thank you. They can get confusion, seizures, coma. So we want to watch for all those things. Yep, sepsis, death. Thank you. Dialysis. Make sure you know about dialysis. There's hemodialysis and peritoneal dialysis. They're different. We assess them differently. There's complications. Think, are we breathing circulation? What can kill them first? So whenever you look at your complications, think about what can cause them to die. What are your expected findings? So hemodialysis, we're going to watch really closely those vital signs, right? Peritoneal dialysis is a little bit slower process. What are they at risk for that's unique that you wouldn't necessarily be at risk for with hemodialysis? Yeah, infection, peritonitis, right? Yes. All right, very good. So yeah, think about, go through hemodialysis, signs and symptoms, complication, things like that. Remember, you're pulling all that fluid off. So what vital sign would you be watching? Or two of them, I guess. BP and what? Yep, yep. So BP would go down, heart rate would go up, right? If they're overloaded, that could be their O2 for sure. Okay. Let's do some questions. Nurse is assessing a client with end-stage kidney disease receiving hemodialysis. Which of the following findings should the nurse identify as an indication the client is experiencing fluid overload? This is a gimme. This is easy. Come on, come on, come on. Thank you. If you gained 5 pounds in a day, okay. Nurse is caring for somebody receiving peritoneal dialysis. The nurse should monitor the client for which of the following manifestations of peritonitis. Ooh, I like this one. Okay, so if I have, so you guys are being tricked up with decreased urine. Okay, so bradycardia. If I have an infection, what's going to happen to my heart rate? Yeah. Hyperactive bowel sounds. What's wrong with hyperactive bowel sounds? If I've got peritonitis, I've got a bunch of like goo in there. Mm-hmm. Yeah. They'd be diminished or absent. Okay. So that leaves us with nausea, vomiting, right? Okay. Nurses reviewing lab data following hemodialysis. The nurse should expect to find a decrease in which of the following lab values? Why do we do peritoneal, or why do we do dialysis? Yeah, we got to pull off that potassium, right? They can have stupid high potassiums. Like potassiums are like 8. What happens if you have a potassium of 8? Yeah, you can die. Your heart gets super cranky. Nurse is caring for somebody undergoing peritoneal dialysis, initial peritoneal dialysis. Which of the following should the nurse report immediately to the provider? What do you think? Which one is bad? Thank you. Because what are we looking for? Yes. Yes. Infection, which leads to. Thank you. Nurses caring for somebody with chronic renal disease receiving therapy with epoetin alpha. Epitin alpha? Epotin? I don't know. You know what I'm talking about. Which of the following lab results should the nurse review for an indication that therapeutic effect of the medication? Why did they take this? Yeah, what's up with them and that? Yeah, they get anemia. Why? Yeah, there you go. So it's not from dialysis. Right, right. What when your kidneys are broken, what do you not make? Yeah, the word yes. Yes. So your body is not going to produce the yes. That's the problem. Erythropoietin. There we go. I was having a brain fart there for a second. So you don't make it because your kidneys are broken. Nurse is caring for somebody with impaired renal function. Which of the following findings should the nurse notify the provider? Yes. Because that is not enough, correct? Yeah, not enough. Okay. Yes. Correct. They need more urine output. It's usually 30 mils an hour, right? Mm-hmm. Okay. I went crazy with the renal questions. Somebody with end-stage renal disease, which are the following expected findings? Expected findings. End-stage renal disease. Fatigue? Yes. Anorexia? Yes. Bradypnea? Slow breathing? No. What about pruritus? They get that itchy skin, right? Yeah. They get that bile salt accumulation weirdness. Makes them itchy. Yes. Hypotension. Is your end-stage renal disease patient going to be hypotensive? No. So our answers are fatigue, anorexia, and pruritus. Okay. Moving on to blood. Blood. Nurses monitoring client who began receiving unit of packed RBCs 10 minutes ago. Which of the following findings should the nurse identify as an indication of a febrile transfusion reaction? Select all that apply. Okay, why is it not A? Yeah, it's not enough degrees, right? It's got to be more than a degree. Yeah. Current blood pressure. Are you going to be hypertensive if you're having a transfusion reaction? No. Hypotensive. No problems. Why we do this, right? What about C, heart rate? Are we going to bump our heart rate if we're having a transfusion reaction? Yes. So generally when you're having reactions to things, you drop your blood pressure and raise your pulse. Client report of itching. So itching is usually associated more with allergic, not febrile. Make sense? Because allergic, right? Allergies make you itch. Fevers don't make you itchy. What about flushing? Do you think you might be flushed if you have a fever? Yes. Okay, so answers C and E. Make sure that you know complications of blood transfusions. What assessment findings would you see if somebody had that complication? How do we give blood? What time? Like over what amount of time? What rate do we give it at? What are the different blood products for? What labs would tell me if my patient is better? So if I'm transfusing packed RBCs, what lab am I going to look for? Thank you. What if I'm transfusing platelets? Platelets. Yes. Yeah. Plasma. Remember, there's hemolytic and anaphylactic reactions. So just look at all the things. So remember, you know, if you're anemic, then you can get some packed RBCs. If you've got bleeding troubles, you want some platelets. Fresh frozen plasma, that also is for people who don't have clotting factors or who are bleeding, right? Who gets albumin? People with edema, sure, shock patients. What group that we learned about needs albumin? Because they don't have enough, and so fluid leaks into places, and then they have nasty signs and symptoms. Who is that? Yes, thank you. Liver patients, liver patients, liver. Remember, they don't produce enough albumin, and so they get this nasty ascites, and they get these huge bellies. Oh, friends, tie it all together. Thank you. Okay. Very good. Anemia. What's the underlying issue with anemia? Yes. it's not getting where it needs to go, right? So think about how that looks on your patient. So when you're assessing your patient, how's that going to look on them? Think about what your priority interventions are going to be. What do you do first? Sickle cell anemia. You need to remember about sickle cell anemia. It's a little bit unique, okay? Think about what the treatments are for sickle cell anemia. And we emphasize it because they get undertreated, and there's specific treatments that you do that can help prevent permanent damage in these patients, okay? Because when they get those little in vessels that get damaged, they can have permanent damage to their eyes and all of their organs and all this nasty stuff that can happen. Okay, so aggressive treatment is really important. So we give them oxygen, we give them fluid, we give them blood transfusions if they're anemic. We treat their pain. Yeah. All right. Pernicious anemia. Nurses providing discharge teaching to a client who had a gastrectomy for stomach cancer. Which of the following information should the nurse include in the teaching? Select all that apply. So what do we need to know about B12 that's particular whenever you've got somebody with a gastrectomy? So monthly injections, yes, correct. It's not going to be absorbed. So monthly injections, yes. Using nasal spray, is that a choice? Yes. Oral supplement. Will an oral supplement work? No, because they don't have the correct setup to be able to absorb it, right? They're not going to have enough intrinsic factor. Eating more B12, is that going to do them any good? No. Soy milk with B12, is that going to help? No, they're missing part of their stomach, okay? So you can throw as much like dietary B12 as you want at them and it's still not going to do any good. Okay, so we've got a six-year-old with sickle cell. These are their vitals. What interventions are we going to do for them? Yes, A. Do we like B? Yes, B. Do we need to keep them NPO? No, not really. There's not really any reason to keep them NPO. Cold compresses. Do we like cold compresses? Warm compresses, right? Cold compresses cause further vasoconstriction, which is part of their problem. IV fluids, yes. Do we like IV fluids? Yes, because that's going to help with the flow of those funky shaped cells, right? Iron supplements. They need more folic acid, right? That's okay. You don't necessarily need it for that. Patient on bed rest. Do we want to keep them on bed rest? So we want to give them folic acid, yes. Bed rest, yes. Remove restrictive clothing. That makes sense, right? We want to do whatever we can to help promote circulation. All right. We're finally to GI. Oh my goodness, we're going to be doing this forever. Okay. You need to know about dumping syndrome. Symptoms, patho, patient teaching. Write that down. Write yourself a note. Bill Roth. Yes. You need to know this. Okay. Let's do some questions. Nurses providing nutritional teaching. Is that important? Yes. Which foods should the nurse instruct the client to avoid? What do we want to avoid? Yep. It's fresh fruit. I don't want them to have fresh fruit. We want them to do canned or well-cooked fruit, right? True or false? Which of these things help prevent dumping syndrome? Do we want them to do fluids with meals? Nope. Eat in a semi-recumbent position. I have that as true. I think about like the disciples' Last Supper. Yes, it's semi-fathers. They're kind of meh. I don't know it's necessarily anything that we tell people to do. Do we want them to lie down after eating? Yes. 3 meals a day, no snacks. No. Small frequent meals, right? Encourage complex carbohydrates, avoiding simple sugars. Yes. And then use antispasmodics as needed. Does that sound reasonable? Yep. Yeah, so they can use those. That'd be all right. TPN. So, yeah, I don't know about that, like semi-recumbent thing. I mean, it's not anything that's in the book. You're not going to be tested on the position of your patient, so don't worry about it. If you are, then I can almost guarantee that that's not on your test. If it is, I will give you points back because I have told you wrong. Complications of TPN. What are complications of TPN? How would you know your patient had the complication? How would you fix it? TPN. Please do a little reading on some TPN and what the complications would be and how you know your patient would have them and how you would fix it. Okay. Here is a practice question. We have somebody receiving TPN. Which of the following findings should the nurse recognize as a complication of this therapy? If you pick B, I'm going to vote you off the island. Because it's not even the right route. Okay, yes, it's A. That's just B is right out. Right out. Like you're not paying attention. You don't know what TPN is if you pick B. And then I have to cry. Because then I feel like I failed you as a professor. Okay, peptic ulcers. Somebody in the ER completing an assessment of a client. Suspected stomach perforation due to peptic ulcers. Can you perforate your stomach with a peptic ulcer? Yes. Which of the following findings would the nurse expect? Select all that apply. Rigid abdomen, true or false? Tachycardia. If your stomach exploded, would you have tachycardia? Yes. Elevated BP. This is a tricky one. No, it's going to be down. Circummoral cyanosis. What is that? Blue lips. Does that have anything to do with your perforated stomach? No. Rebound tenderness. Is it going to hurt if I push on your belly? I would think so. What intervention are we going to do first for this person? Remember, we've got to figure out if they are stable. So what are we going to do first? Yes, NPO. Okay, don't feed them. How do we know if they have ABCs? What do we have to do? Vital signs. Get some vital signs, right? Fix things that are broken. What else do they need? What meds? Yeah, they need pain meds. Yes, they need pain meds. But what's the thing that's going to keep them from dying? Yes. Thank you. Say it louder for the people in the back. Antibiotics. Okay. So yes, we want to treat all of those other things, but yes, antibiotics, because we don't want them to get sepsis and death, right? So let's check their vitals. Probably give them some fluids. They need antibiotics so they don't die from their peritonitis, right? Let's give them some oxygen if they need it. We might drop an NG tube, right, to pull out any stomach contents so we don't continue to leak nastiness into our peritoneal cavity. Y'all with me still? Yes, Emma, what's up?
With the antibiotics, is that just like because of the bacteria from the stomach, I'm assuming, right?
Yes, because they can get peritonitis.
Okay.
And then
Okay.
sepsis.
Sorry.
No, you're good. And then they die. Correct. Because you just have, like, your gut's not sterile, right? So any like stuff from your stomach going into your sterile peritoneal cavity can cause death. Well, not ultimate death, but peritonitis, right? Which of these, if you have peptic ulcer disease, would be the most serious finding? Okay, coffee ground emesis means what? A bleed, but what kind of bleed? Old blood, because it's had time to be digested. So it's not bright red. Bright red is bad, right? Because bright red is like arterial. Coffee ground emesis is old blood. It's been hanging out for a second. Projectile vomiting, not ideal, but not going to kill you. Burning sensation after 2 hours after eating, you have a peptic ulcer. So sorry. Board-like abdomen with shoulder pain means what? Ultimately, yes. Yes. So possible perforation. Okay. Peritonitis, sepsis, death. Okay. Gastric ulcer. So we're assessing somebody, which of the following findings would the nurse expect? Select all that apply. If you have a gastric ulcer, is it going to feel better when you eat? No. Occurs at night. Who gets the night pain? Duodenal, right? Yeah, however you spell that word, yeah. Sensation of bloating. Do you get bloating? Yeah, everybody with ulcers gets bloating. Pain occurs 30 minutes to an hour after a meal. That makes sense, right? Gastric ulcer, we start throwing out some digestive juices. Pain upon palpation of the epigastric region. Does that make sense? Yes. It's going to hurt when we push on it? Sure. Okay. Okay, we have somebody with small bowel obstruction from adhesions, which are consistent with this diagnosis. What kind of assessment findings would you have if you have a small bowel obstruction? A? Do we think A? Yeah. Spasmodic. Yeah, fecal odor, it can be, depending on where your obstruction is. Spasmodic abdominal pain. Yeah, your body's trying to push it through. It ain't working, but it's trying. High-pitched bowel sounds. So it kind of depends where you're listening, right? So yes, you can have high-pitched above, but quiet underneath, like below. Their abdomen is not going to be flat, right? If they've got a small bowel obstruction, what would it be? It makes sense that they'd be bloated, right? Yeah. Lab findings with metabolic acidosis. What do we think about that? Yes, Michelle. So let's think. Metabolic acidosis. I don't think that they necessarily at risk for metabolic acidosis. Right? I mean, if you have an NG tube, they could be alkalosis. But not necessarily acidosis. Yes, emesis could be alkalosis, yeah. But there's nothing that would make them acidotic, right? So my venture is that nothing's going to make them acidotic. They're more likely to be alkalotic. Ashley's going to fire me. Ooh, both. You win. So they're at risk for both, either. It will not be on the test. I've now lost all credibility with you guys. Moving on. Pancreatitis. Can we just agree that acid-base imbalance is like confusing? Don't get stressed. It's all right. It's confusing, yeah. Especially like GI stuff is like, what? Because it's not as straightforward. I can't take them out. You still got to work on it. The first two. Yes. And so in reality, you get these like mixed acid-base imbalance. It's generally not quite as straightforward as what we're giving you. I mean, it can be, but a lot of times you have this weird combo. We just don't go into all that detail because we don't want your heads to explode. Fair? Okay. I know. So don't get too caught up in it. Just, we won't make it that hard. Okay. Nurse is completing the admission assessment of a client who has acute pancreatitis. Which of the following findings is the priority to report? Select all that apply. So think priority. What is a priority? Yes, because they can have respiratory complications. Yes. Yes. What is another priority? So there are things that we would report and that we care about, but there's one other thing that is a priority. Yeah, E. Why E? What is that telling us? Yes, it's calcium, right? Yeah. So remember, with pancreatitis, you get fat necrosis and you get hypocalcemia. Okay, when you have hypocalcemia, it can cause seizures. Okay. So that would be their problem. So decreased bowel sounds, maybe. Amylase, we expect it to be elevated. History of gallstones, sure, that can cause your pancreatitis, but the complications here are the crackles in the lungs and this hypocalcemia, right? Nurse is completing nutrition teaching for a client who has pancreatitis. Which of the following statements by the client indicates an understanding of the teaching? So which one is correct? Which all of them are correct? So this is after they're over their initial needing to be NPO. Yeah, we like small frequent meals, easy to digest, limited spice, we like that. Skim milk when cooking, do we want them to lower their fat content? What's the problem with regular cola? But yes, milk can aggravate it. Caffeine is bad, yeah, and it's acidic, yep. And then limited alcohol intake. Do we like limited alcohol intake? No, we gotta just stop it because that can cause our pancreatitis, right? And that can make it worse. Okay. What's the problem with pancreatitis? So remember, yes. Yeah, problem with pancreatitis is it's digesting itself, right? So in the initial pancreatitis, we've got elevated amylase lipase. Do we feed them? No. Okay. Keep them NPO so they don't continue to auto-digest. How do we know that our pancreatitis patient is not ready to advance their diet or that we need to pull it back? What is going to start happening again? Yeah, they're going to start hurting again, right? Yeah, so if you've got this return of pain, that means you need to back off. Okay? Liver. Portal hypertension. Hepatic encephalopathy. Treated with lactulose. What lab are we going to pay attention to? You will not get a question this easy. Okay? This is too easy. But do you need to know about portal hypertension? Yes. You need to know about hepatic encephalopathy? Yes. Lactulose? Yes. Ammonia? Yes. Just to jog your memory. Yeah. There are some easy ones, I think. Okay, complications of liver disease. What is the most life-threatening complication of cirrhosis and considered a medical emergency? Talking about copy and paste. What kind of varices? Oh, which one is it? Esophageal varices, right? Esophageal. Yes, esophageals. Ruptured esophageal varices are the most life-threatening complication of liver disease because you will bleed out in a hurry. A nurse on a med-surg is admitting a client with Hep B and ascites. Which of the following actions should the nurse include in the plan of care? Do they need contact precautions? Do we want to weigh them weekly? What's the problem with that? Yes, Yes, every day. Measure abdominal girth. Do we really measure abdominal girth? Daily weights are better. Yeah. Provide a high calorie, high carb diet. Which one is it? They don't need contact percussions. We don't want to weigh them weekly. We're not going to do abdominal girth because we don't do that anymore. Yes. High calorie, high carb. Look up some dietary stuff for your liver patients, please. What are the causes of cirrhosis? Please know them. That's the most common, right? Oh, I forgot to go on this. So make sure you know the causes of cirrhosis and risk factors for the hepatitis. So there's different types of hepatitis, right? And different things that can cause you to get them. So please review them. Don't spend too much time on like, I think there's hepatitis D and E and some ridiculous, ABC, know those, okay? Yes, ABC. ABC. Patient had a stroke, right cerebral hemisphere. What are we going to watch for? Yes, impulse control. Stroke, left cerebral hemisphere. What are we going to watch for? Yes, intellectual impairment. Oh, did I misspell it? Oh, okay, because that would have been really ironic if I misspelled it. Not surprising, just ironic. Okay, clinical manifestations of a hemorrhagic stroke. What does it look like? So neurodeficits, headache. If I have increased ICP, I can have some nausea, vomiting, right? Level of consciousness would be what? Yep. What about my blood pressure? What happens to my blood pressure? Actually goes up. Hyper. I know, it's confusing. Hypertension. So hypertension can cause the hemorrhagic stroke, right? I know it's confusing. You can't bleed that much into your brain, right? The space is small. And we're trying to get it perfused, right? It's a common finding. Yes, it's trying to get more blood up to your brain to perfuse it. PPA. Know all the things. Know about care of post-stroke issues. As always, know about patient teaching. Bipolar. Nurses delegating care. What you got? I want you to look that up. So mostly you just need to make sure they're stable, right? If they're stable, we start them on like PT, OT, all the things very soon afterwards. But you're not going to do that with somebody who's not stable. Oh, I mean, you're not going to have a specific question about return to physical activity after a stroke. Just know that we encourage them to get back to moving as soon as possible after their stroke. They're not going to sit in bed for 4 to 6 weeks. That would be bad on lots and lots of levels. As soon as they're physically stable, then you would resume activity to as much as they could. They try to get them up and moving ASAP. All right, nurses delegating care of a client with bipolar disorder to an unlicensed assistive personnel. What instruction is critical to a successful plan of care? Yes, limits, right? Very good, limits. Nurses completed the admission assessment of a client with diagnosis of acute bipolar disorder. Based on the assessment, what is the priority focus of the nursing plan of care? What are our priorities? Okay, so think about what are our priorities. Yes, hydration and nutrition. Those are basic physical needs that we need to meet. Until we can get them sorted, right? We need to make sure that they're hydrated and eating. So we don't want physiologic complications, okay? Make sense? Okay. Also think about how we would, so yes, hyperactivity could be an issue, but we're not going to control their hyperactivity. You need to like work through it until we can get them managed. While we're trying to get that under control, we want to make sure that they have a sip of water, right? We throw a granola bar their way. While we're trying to get them better, they need to maintain physiologic functioning. That makes sense? Okay. Nurses assessing somebody with bipolar disorder in the manic phase. What assessment finding could pose an immediate safety concern? Select all that apply. Potentially, yes. So immediate safety concern. Is noncompliance with medication going to be an immediate safety concern? Annoying? Yes. Immediate safety concern? No. So I know it is tricky. So non-compliance with medication is more of like a long-term, like just annoying thing. But D, risky impulsive behavior. That makes sense, right? That's an immediate safety concern. So yes to D. Inflated sense of self-importance. So you could twist this to say that that could be a thing, but no. I mean, really, they're just kind of like talking about how awesome they are or how important they are. But is that going to hurt them? They're not jumping off the building. They're just talking about how important they are. So they're saying they're important. Put that against purposeless movements. Now, purposeless movements, that's more problematic, right? Yes, we're working backwards. So D, yes. B, we see how yes for B, purposeless movements. They might hurt themselves. They might hurt somebody else. And then yes, distraction by environmental events. That could be problematic as well. Yes, so A, B, D. It is her. It takes some mental gymnastics. You could. Try not to read too much into him. If they don't pay attention to environmental things that could harm them. Yes. Yes. Nurse is teaching a client who has a new prescription for lithium. What do we want to make sure they take enough of in their diet? Y'all are so smart. Good job. Okay. With bipolar, make sure you know about safety. Make sure you know about nutrition. So there's specific nutrition considerations with bipolar patients, particularly manic patients. Okay. Know about patient teaching. Know about risk factors. You're going to have a question on the milieu. What is the milieu? Thank you. Stages and associated signs and symptoms. I know, isn't it lovely? Milieu. It sounds like what it is. So stages of bipolar, and what are your signs and symptoms at the various stages, okay? And what are our nursing diagnoses going to do? Are going to be. Okay. Moving on. Schizophrenia. We got somebody with a diagnosis of schizophrenia. Client states, I keep hearing voices telling me to run away. What response by the nurse is appropriate? Do we like A? Nope. Okay, so we can eliminate A. What's the other answer choice we can eliminate? C, right? Because you're dismissing them. So that leaves us with B and D. Can you tell me who the voice sounds like and what you think you need to do? D, try and listen to me and others around you that you can see. Which one do we think? So I think we could, so he's telling you, the voices are telling me to run away, right? So the voices are telling me to run away. So you know what the voices are telling him to do, right? So it's not necessarily B. So by telling them D, listen to me, you're reorienting them, right? You're putting them into the present, you're putting them into reality. bring them back to what we can actually, what reality is. That's why it's D. Does that make sense? Because B is, they think that they need to run away. Yes, exactly. Putting on the purple gown. You guys know what the purple gowns are? They have them at St. David's. I know, we wear purple too, but at St. David's, their psych patients wear purple, which they always laugh at us at St. David's when we come rolling in with our purple scrubs, because that's their color of their psych patients. I know. I know. Yeah. While walking through the dining room, the nurse overhears the client with a diagnosis of paranoid schizophrenia and whisper to another client, "They are all out to get us and probably poisoned the food too." What would be the priority nursing action? This is a tricky one too. Okay, so what's the problem with A? So the nurse overhears the client talking to somebody else. You catch that? So are they talking to you? They're not talking to you. They're talking to their friend. You're eavesdropping. I know. Do you think that's going to help your paranoid schizophrenia build some rapport with you? Yes, Dolores. Yeah. Also, you can't take a bite of the food. They could say something about, like, well, it's only going to make us sick because you've received the antidote. I don't know. D or B is dismissive, right? C invites yourself into the conversation so you have an opportunity to talk, right? And then D is also dismissive. So yes, it's C. The answer is C. So then you have an opportunity to be a part of the conversation. You haven't been shady and eavesdropping, right? Okay. Yeah, if you eavesdropping on a paranoid schizophrenic, you're just feeding into their paranoia. Yeah, exactly. Blah, 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 blah. The nurse is instructing unlicensed assistant personnel who will be caring for a client with a diagnosis of schizophrenia. UAP is asked how to deal with a client who reports hearing voices. What's the appropriate response by the nurse? Is it A? No. Is it B? No. Is it C? No. D. Ask. Yeah, ask. What are they saying? We need to figure out what they're saying. Okay. We're almost done. We're almost done. Nurse is caring for client with the inpatient psych unit. Client tells the nurse that someone is poisoning the food and the drink here, and they will not eat or drink anything. What therapeutic response from the nurse would help the client? Tell me more. Correct. Tell me. Tell me more. Okay. always tell more with mental health? Pretty much, yes. Exactly. That way you can understand more of what they're thinking, so you can speak to it. So know the terms. There's lots of terms in schizophrenia. Example, positive versus negative symptoms. Positive, we're adding stuff that we wouldn't expect to be there. Negative are things we would expect people to have, but they don't. Yes, Carrot, what you got?
Just sorry, just a quick question. I was trying to write some of this stuff and I'm missing a lot. So, do you know when this is going to be like sent to us?
What are you talking about?
The video, I'm sorry.
Oh. I mean, it takes some time to get it posted, like to upload on the internet.
Mm-hmm.
So I can get it up probably tomorrow morning-ish.
Oh, okay. Thank you.
Yeah, it will be tomorrow for sure. And I'll try to do it early in the day. I might not get it tonight because I'm old and I go to bed. And if I go to sleep now, I might be able to get enough sleep tonight before my baby wakes me up 14 times. But yes, no, I'll get it up tomorrow for sure. Oh, I know, for reals. Okay, so positive versus negative symptoms. Remember to look those things up. And then the different types of assessment findings. Stages of schizophrenia, okay? Therapeutic communication, we've practiced a little bit already. And then just like with your bipolar patients, safety, safety, safety. Because if they're not safe, it doesn't matter. Anything else, it doesn't matter. Quickly, seizures. Who's at risk for seizures? Everybody. Everybody is at risk for seizures. All of these people. Like any of them can have a seizure. It makes you like nervous to take care of anybody because they can all have a seizure on you. So just know lots of things can lead to seizure land. This always reminds me of nursing students. Excessive stress, overwhelming fatigue, acute alcohol ingestion, caffeine intake. Not the rest of it, but a couple of things. No, you're not gonna seize. I took care of a law student one time who was like downing energy drinks, like having arrhythmias. Like, dude, make better life choices. Seizure precautions. Know your seizure precautions. We put our side rails up and we pad them. Bed in lowest position. We have oxygen set up because they could be hypoxic. Make sure you have an IV. That's how we give them their medicine. Suction because they can aspirate. Provide them privacy. Watch the seizure so you can take notes. We'd want them to not get injured any further, okay? So what's the big deal with the seizure? Why does it matter that a patient has a seizure? Yeah, so they use up all of the glucose and everything, right? And it can cause brain damage. So if you have a seizure that lasts too long, you can cause permanent brain damage. Sorry. It's a thing. So that's why we want to help them not seize anymore. Meningitis. No care of meningitis. What are the priorities of meningitis? What is a priority intervention for meningitis? Hit me up. What is it? What do they need? Yes. Well, yes, they need a vaccine, but if they already have it, we want to get them antibiotics as soon as we can. We need to do our cultures first, right? We need to isolate them. Remember that they're going to have neuro signs and symptoms. We want to decrease stimulus in the environment, those sorts of things. but we need to get those antibiotics on board until we make sure that it is not bacterial versus viral. Complications, increased ICP, right? They can have sepsis. Both of those things can lead to death. So remember, your bacterial meningitis is really nasty. We need to get them treated as quickly as possible. Yes, they can have residual, lasting brain damage. And then signs and symptoms of those complications, okay? So make sure you know all these things. Do we need to know? I mean, you might have a question on cranial nerves. I wouldn't spend a lot of effort knowing all the cranial nerves. It's not going to be 10 questions, right? It might be a question. Test taking tips, sorry. ABCD, right? Airway, breathing, circulation, disability. Look for any changes are expected. So if they have altered level of consciousness, it's never normal. Fever is never normal. Abnormal vital signs are never normal. So you need to be able to recognize what normal is, okay? So know what normal is, and then you can recognize what abnormal is. Know what your typical complications are and what your worst case scenario is. What does it look like? What are we going to do to fix it? Don't forget your rules of delegation. You're going to have a couple delegation questions, right? Complication is death. If a med has a particular side effect, you need to know it. We've already talked about that. Know thy normal labs, or they shall make silly answer choices. When we're talking easy questions, there's always a couple easy questions I have to do. If you knew the normal lab values, you'd get it right. But y'all don't remember, and so you miss silly things. So make sure you know your normal labs. Additional resources. Okay, so the Nurse Think stuff is old. I deleted it, but it didn't. I updated this, but it didn't update here in Blackboard. So anyways, you can go back to the previous recorded reviews. You can go back to the previous recorded lectures. Not Nurse Think, but ATI. ATI has got the book. So Alice, we did not copy and paste any questions from your previous exams, if that's what you're asking. But nice try. ATI, the book and the website, okay? System disorder guides are also very helpful. So those system disorder guides are in the back of your ATI book. I do love them. You do have your case study book, and you have the Evolve case study book. And then I like this one. It's pretty. So, thanks for hanging in there. Hopefully this was educationally valuable. I'm so glad so many people showed up. A baby picture. Okay, hold on one second. Okay, so you have to show up to lecture to get the